Hello. Today on OMED 1401, we are going to look at the assessment of the neonate. So, in our last chapter, we looked at the assessment of the newborn. We know that a newborn means that the baby's literally just come out, the placenta is in the room. We looked at two different scenarios, the first being resus, be prepared to resus, know your resus algorithm. And the second is a general assessment of the well newborn. So, just to recap, what we did in that was basically the initial assessment of birth, and then dry and warming the baby, then the ABCAR score, and then looking at red flags. So, not a great deal to do in our assessment of the newborn, providing the baby's all right. Anyway, today's lesson is the assessment of the neonate. Now, that's a little bit different because this is the baby in the first 4 weeks of its life. So, up to 28 days old after it's been born. What we're looking at today, as usual, is to have a different understanding and a different approach to assessing a newborn. So, we're thinking about systematic approach. Recap on terminology. We've just said that a newborn, placenta is in the room, a neonate is up to 28 days old. Now you're going to start to think about what the other pediatric terminologies are too. So if someone refers to an infant, generally that means in between a neonate and 2 years old. Now you'll notice here, you'll be like, yeah, well, what if it's like a leap year in February and the child is 29 days old? Right, okay, so that's why it says a month. So basically you can call that a neonate anyway after 29 days old. It's fine, calm down. So infant, 1 month to 2 years old. Child is in general between 2 and 12 years, and then above 12 is the adolescent. Now, you'll find different books with different terminology, different countries. This is what I'm going on. This come from the World Health Organization. Yes, it's a little bit dated. I think it was 2011. But as far as I'm concerned, this is the terminology that we will be using on this course. All right, a cute little baby there, isn't it? I enjoyed looking at pictures of these. So our general approach is going to be pretty much the same as pediatric. So initially, we're going to be checking our primary survey. So hands-off approach, have a look at this little baby up to 28 days old and check any response from it. Is the baby moving, crying, etc.? Is there anything in the airway? Make sure that you don't have to do resuscitation. Otherwise, you're going to go straight through the pediatric triangle. So you are going to check the work of breathing. You are going to check circulation skin. You are going to check appearance by using the mnemonic tickles. Once you confirm that there's nothing serious happening there in the pediatric triangle, reconfirm your ABCDEs. So you might need to take some observations here. That's fine. You can take your observations and get a general history from the parent. So what seems to be the problem? Making sure that this is not time critical. So I'm not going through all of that stuff again. We've been through this in newborn, we've been through this in pediatric, and even all of the adult stuff. Right now, it's going to be a couple of days. It's going to be February 2021. You're over halfway through your second year, so we're not going back to all the time critical issues. So confirming this little dude or little girl or little whatever doesn't have any time critical issues, doesn't have anything that you need to immediately correct, you're going to move on to do a general neonate assessment. Tick, tick, move. Tick, ding, ding. All right. So this is how we do the assessment of the neonate. Generally, we're going to take a rough history. If it's a pain or something like that, you can go through Socrates, but what most of the time we're doing is just general unstructured history taking initially. So we say to the parent, what seems to be the problem? When did it start? All that kind of stuff. Now, what I want you to do is after you get your initial history of what the problem is, I want you to move on to a better history taking model. Now, as you know, my preference in history taking is the medical model. So we'll do on arrival, on examination, past medical history, any surgical history, etc. We might do a review of systems. If it is particular, like a respiratory problem, I might go into respiratory system. I wouldn't really recommend doing a Socrates or an OPQRST because that tends to be about pain. But if that's the only one you can remember, then that's your prompt. Then you can go down it. So if it's something like baby's always crying, then you'll have to do, right, okay, Socrates, sight. There is no sight. Okay, onset. So when did the baby start crying? You know? So you're going to have to like make it work for you. Whereas a medical model, you can go through each step and try and find out a lot about the history. Whilst you're discussing the history, I want you to move on to the maternal history. So, what that means is how was the baby through the pregnancy and how was the birth? So, in that, you're going to take a history from the parents. Say, tell me about the birth, tell me about the pregnancy. Were there any issues? Were you hospitalized? Were there any infections, etc.? How long did the birth last? Was the birth using was it using forceps? Was it natural? Was it using cesarean section? Was there much bleeding? Once we come on to the obstetric session, you'll probably learn a little bit more about what you're going to ask in that. We do have a section coming up as well on the maternal notes, so that will give you prompts in which to ask about the history of birth. After you do that, you're going to assess feeding. Now, with a child in the first 28 days of its life, feeding is really important. In those first 28 days, life is crucial. So this is where you find out the feeding patterns. How often do they want to feed? What kind of stuff do they like? Are they going to be breastfed? Are they going to be bottle formula fed? That kind of thing. You're going to find out if there's any congenital issues. So if they're born with any type of issues, that will get flagged up within the first 28 days usually. It's going to be a really crucial time for bonding between parents and the baby. So these first 28 days are very, very important. Anyway, back to assess feeding. Going to go into a little bit more detail about feeding and nappies. And this will give you a general overview of how strong the baby is going to be, how they're developing in terms of nutrients and digestion. After the feeding, we're going to look for signs of pain, and that just means consider the position. So a normal baby will be all quite wriggly, etc. A baby with abdominal pain, for example, will be quite crunched up. After that, well, in amongst those things, so in assess feeding and consider position, you're going to be thinking about digestive illnesses. So normally intestinal illnesses, and we've got three here that you'll be looking at in particular. That is volvulus, intussusception, and pyloric stenosis, the three diseases of the digestive system that are very common. Well, not very common. There are not common, but when they're detected, it's usually in the first 28 days. You're going to be thinking about red flags. So any signs of infection, and especially those signs of infection that might turn into sepsis. Always thinking about sepsis with babies, with infants, with pediatrics, with children. We're going to be looking at dehydration. Yes, again. And we're going to be looking at hypoglycemia, because this is when, with the feeding habits developing crucially in the first 28 days, then also any diabetic habits or hypoglycemia will tend to occur around then. I must say that the infections as well, that up to 28 days old tend to be really severe if they are getting infections. They don't tend to get little minor coughs, colds. So any infections that you do see in this age group, please take seriously and think about sepsis. Lastly, as always, we are going to be considering safeguarding. So if this is your OSCE, I don't want you just saying, I would consider safeguarding. I want you talking about all of these things. So hopefully we'll get practice in this when we do our neonate session. But for now, let's crack on. Move on. Right, so the history that you're going to get from the pregnancy notes, This is when I want you to be quite confident, and you might have to act a little bit. So if you go in to an up to 28-day-old baby, you're probably going to be a little bit crapping yourself, a little bit like, unless you're really, really used to babies, people tend to be a little bit like, oh, it's a baby, don't want to break it, that kind of thing. Be confident. So, first time you look at those maternity notes, don't let them know it's your first time. You say, "Oh, may I see the notes, please?" Oh, yes. Have a little flick through them as if you know them. Take it all in. See what it's about. See what kind of stuff they write down there. And if you don't know the abbreviations in there, then make a point of finding them out. When we come on to our obstetric session in a couple of weeks, you'll learn a little bit about some terminology there. But, I don't know half of the terminology. We are not midwives, we're there for emergencies. So if you don't understand something, you can ask somebody. Right, so we've taken a general history from the parents or caregivers. We know what they think the issue with the baby is, whether it's won't stop crying or got a red face or got a rash or just vomited loads or hasn't pooed in 2 days. Whatever it is, you've taken that general history and found out as much as you can about the current situation. So because this child, this neonate, is basically not going to have much of a past medical history, you got to figure out about what happened to it during its birth and in the months leading up to its birth. So this is called the maternity notes. So they're handheld notes, a little bit like this picture here, and you will have normal antenatal notes. There is a section in here for the intrapartum notes, and that's everything to do with labour. So basically what happens at the first appointment, the notes are started. And I do that. I know it's really annoying, but that's what they're called. Have you got the notes? They know exactly what you're talking about. Just like the little red book, everyone knows what the little red book is. It's your pediatric record. Now, have you got the notes? They know that you mean the handheld antenatal records. So they're green like this. They have different sections to them. Like I say, it starts on day one when they have their first appointment, and everything's documented in there. So on the front cover, you'll see things like the name, hospital number, NHS number. Inside, once you have a little flick through, you'll notice a lot of information about the birth mother. So the birth mother, all her medical history will be there, her past medical history, surgical history. There will be things about allergies there as well. There will be plans. There will be a health and family support assessment. There will be details of appointments, what happened during the appointments, and any hospital stays or antibiotics or treatments, anything like that that might have come out of clinical assessment in those times she went for her checkups. If there's a particular care plan, like a person might have individual needs, the details of that will be in the notes as well. And any, like I said, any inpatient records. Now, it might take you a while to find out all that information because every time this lady goes for an appointment, there's a lot of information written down. Now, we all know that medical professionals love jargon. So, like I said previously, some of it you'll understand, some you won't. You can ask the parent. You can say, "Oh, what's this about here?" These notes are written by healthcare professionals for other healthcare professionals, and with mother in mind, that they can look through their own notes. So there's no secrets in here, nothing private in here. So they should be quite happy for you to have a look at the notes. When you get to the interpartum notes, you'll be looking at things like, okay, what time did the labour start? How long did it last? How long were the contractions? How painful were they? Did she use any type of analgesic? What type of analgesia? What was her reaction to that analgesia? They will note any bleeding, any tears, any stitches, sutures, anything that happened during the delivery and straight away afterwards. How long was it between the baby being born and the placenta being born? So that little tiny neonate's full medical history is there inside those notes. So even if you're going to a neonate call and you're taking the patient in or whatever, even if you think, oh yeah, we'll just bring the notes along with us, my advice to you is have a little look. See the kind of things that are written down. This will really, really help in your history taking because it'll become natural to you to ask about the birth mother's history, to ask about the baby's birth history and development history. So get your nose in there, figure out what it's all about. Next is feeding. Now, you need to know the landmarks. I'm sorry, I'm getting thirsty again. Yeah, you need to know the milestones, is what I'm saying. You need to know how often neonates do tend to feed so that you've got something to compare it to. Remember, we talked before about normal ranges? Something might be normal for one person that's not normal for another. So we'll find out from the birth mother or the parents or the guardians, whoever's there, how often the baby's feeding and what they're feeding. So, first question is the baby feeding well? What does that mean? Well, basically, when the baby is attached or offered to the breast, does it latch on? Does it start to feed immediately? Does it tend to flop off to sleep? Even when there's a chance of being fed, is it more interested in going to sleep? That can be a bit of a worry. Do you need to wake the baby up for feeding? That can be a little bit of a worry as well. So, regular healthy babies tend to wake up like every 3 hours and be like, "Wah! Give me some food, give me some milk," or whatever. When they don't do that, we think, why? Why don't they do that? So you don't have to decide why, but you can say, oh, that doesn't seem quite normal. Well, you say it to yourself, you don't say it to the family. That doesn't seem quite normal that the baby's only waking up like every 6 hours for feed. It's a tiny little baby. It should be every 3 hours. So, how often and how easy is it to get the baby to feed? So, the last thing there to think about is, does the baby actually attach and is nice sorry, that sounds so wrong. I'll carry it on anyway. Nice rhythmic suckling. Yeah, sorry. Fast forward me, ignore me. This isn't funny at all. So, yes, is the baby latching on and getting a really good feed, or does it need persuading? So, that's is the baby feeding well. Feed frequency. So, 8 to 10 feeds in 24 hours. That works out with about every 3 hours. That's what we're looking at. God, no wonder these people don't get any sleep. So those tiny, tiny little preterm babies that didn't get to the full gestation before they were born, sometimes they don't feed responsively. What that means is their body doesn't say, wake up and get some food. They just kind of will stay asleep. They'll sleep through it. Preterm babies need to be woken up to say, come on, let's have a little feed every 3 hours. So you might attend a family where the baby isn't really feeding well and they're like, oh, baby's lost a lot of weight or whatever, baby's not, seems really weak or floppy or whatever. And, ask, was the baby full term? This is going to come along in your notes anyway. It's going to be written in there, but it's a good thing for you to ask. So if the baby was premature, there is a chance that they're not going to be feeding unless they're woken up for the feed. So alarm will have to be set, mama, and you're going to have to get the baby fed every 3 hours. Moving on from feed frequency and if they're feeding well, let's look at the nappies. So ask about nappy behavior. So wet nappies, so urine, there should be at least 5 wet nappies in 24 hours. So if the nappies aren't getting changed that much, we're looking at a safeguarding issue. If parents are looking in the nappies and it doesn't appear to be anything there, we're looking at maybe a urinary retention. So that could be a red flag. So note to yourself, yeah, there should be about 5 wet, heavy nappies in the last day. Ask the parents, ask the caregivers, how many wet nappies were there in the last day? As for poo-poo nappies, well, minimum of 2 dirty nappies in 24 hours. And when we say dirty nappies, we're thinking 2 pound coin size plop, little cow pat, little splat of little poo nappies. They're not solid at this stage yet. They're just little splats. So I'm sure there's a much more ladylike way of putting this, but guess I'm not a lady. All right, so the first 2 days of baby's life, it's all right to have one little splat, and you might have a little splat of meconium. That's all right in the first couple of days. But after that, we're looking at a minimum of two. And you're probably looking more like 4 or 5 in a day. And they are normally kind of like greeny, browny, yellowy color. They're not our perfect brown poos. They are only from milk, so there will be of a different consistency. If you've never seen a baby poo, like a 28-day baby poo, Google it. I mean, I don't know what other sort of stuff is going to come up if you're Googling things like that, but if you don't know what it looks like, get a glimpse of it so that whenever you come along and you say, I remember Gemma saying it's going to look like a little bit of a splat, so that you don't get a shock. All right, let's leave that one there. So we're assessing the feeding, we're getting a general overview of how much the baby is taking in. This is going to be really important when you come along to look at the intestinal diseases, but also when you come along to look at hypoglycemia. So you're gathering a history, not through your normal history taking methods, but through what has been vital in the 4 weeks or less in this tiny neonate's life. Right, so you see where we're going with this. Let's move on to our intestinal diseases. So we got a couple of pictures here, so hopefully you won't need to carry on looking at me too much longer. So what is volvulus, first of all? It's a problem in the small intestine where it kind of twists round on itself like that. The bit that's left there gets starved of the oxygenated blood and becomes necrotic. So basically, if you just imagine like twisting a balloon or something like that, anything, if you were trying to get more air or more fluid into that balloon, it wouldn't go in because the twist part has left it cut off. So the blood supply is cut off to that part of the intestine. So let's read a little bit about it. So, it's caused by a defect at birth. It's not attached as normal to the abdominal wall, and that makes it possible for it to twist. So this is something that happens before the baby is born. It's a defect. So the intestine is not stuck to the abdominal wall, bits come away, and that makes it able to get twisted around each other. Once that bowel becomes necrotic with a lack of blood supply, the tissue is going to die in there. All right, so that's a bit of necrotic dead tissue within this baby. So you might think, oh, so what? I can use lots of the rest of the intestine. It's a big, massive deal. So this baby needs surgery. Now, how the heck are you going to find something like that? I don't have X-ray vision, all that kind of stuff. How are you going to find that out? The signs and the symptoms, I'm pleased to tell you, poo poo. So you can have a little look at the nappies, and again, the splat might be a little bit different from the normal splat. So first of all, you might get some vomiting. Because it's in the intestines, this vomiting will come out as green. It will look like bile. It says here that the child might have abdominal pain. Do you remember what I told you about babies with abdominal pain? It was not too long ago. So we look at their positioning. So the normal baby wriggling around, the legs are a little bit apart, bent at the knees, that kind of thing. The baby with abdominal pain, so the baby with volvulus, will crunch its knees right up and be in a curled position, all right, like appendicitis. Those things where if you stretch, it makes it worse. So you curl and you crouch. So the stools are bloody or dark red. That's how you'll notice this, by the position, by the history, and by the stools. You might get constipation with it. You might get a swollen abdomen with it as well. But that's quite hard to detect the swollen abdomen in the baby because, like when they feed, their little tummies swell right out and then they just go down and down and down and down. And then they swell again after the next feed. And so it's very hard for parents to to say, well, yeah, that abdomen is distended, because they don't know just yet, because the baby's changing so much. So we are looking mainly at the stools, at the history, and if there's any type of positioning that would signify abdominal problem. This is really bad because, as you can imagine, this little twisted portion that dies, that can cause hypovolemia, lead to shock, and I'm sure it can lead to sepsis as well, with the poisoning coming out into the bloodstream. So very serious. Need to bring them into hospital and need an operation on it. Now, I wouldn't necessarily say that I need to blue this patient in. I wouldn't necessarily say I need an ash ice, but this patient definitely needs to go to hospital. They need ultrasound and scans to confirm that there is a volvulus there, and then they need to get it sorted. All right, so do not leave this at home if you are suspicious of it at all. Okay, so the next intestinal um, problem here, let me move this for you, is intussusception. And somewhere along the notes, I will have spelt this wrong because I just can't spell it right. Intussusception. I always write intra. So what's happened here is the bowel telescopes into itself. So it's a bit like you've got like the tube like that, but it folds back in. So it's a bit like, if you can imagine, when you take, boys, when you take your tights off, or they kind of the leg of it goes back into itself, or your socks, of course. I should have just said that. So it folds over on itself. If you can picture what I'm talking about, and you have a look at these diagrams and you're still like, what does that mean? Just YouTube it. YouTube intussusception, and you'll see lots of different images of it, and one image will sit with you. So yeah, some reason the normal bowel has telescoped inside on the other one, and that is going to cause an obstruction. It will lead to the bowel being completely blocked, and the blood flow will either completely reduce or not get to that part of the bowel at all. So a little bit like volvulus, this is an intestinal problem where the blood supply is getting cut off and the bowel itself is becoming damaged and dead. Um, Again, that's going to potentially lead to hypovolemic shock and potentially lead to septicemia with the blood poisoning. So symptoms of this, not too dissimilar from volvulus. So with this, we're having intermittent severe abdominal pain lasting 2 to 3 minutes. So the baby's going to be crying, they're going to be changing position, they're going to be really, really distressed for a couple of minutes, and then it stops. But during that time where it stops, they don't have the energy to keep going. So in that little time frame where they're not screaming and crying and hysterical in pain, they're going to be tired and floppy. They're going to be pale. You are going to be worried. The parents are going to be freaking the hell out. So good to know about what might be going on. Right, so we've got that. This child is behaving strangely. They look like they've got abdominal pain because of the way they're crunched up. They are screaming hysterically for 2 minutes and then stop and get floppy and then wake up again and do it again and again and again. Why are you acting like that, little weirdo? It's because you got an intussusception. So let's have a little look at their tummy. Physically inspect it. You can have a slight palpate as well. It might make them more distressed, so be careful as usual. It's possible to palpate this abdominal mass because it will bulge a little bit, but I'd be careful about causing more distress to the baby, so only do it lightly and don't spend an awful lot of time doing it. Now, the great thing about this is in your detection skills, when you have a little look at the nappy or when you get the parent to describe the splat, it is red jelly. It's red currant jelly, black currant jelly. They will talk about it. So again, YouTube it or do your Google pictures or whatever, and you'll see this little lump of strawberry jam. Well, red currant jelly. Sorry, not strawberry jam. Red currant jelly in the nappy. That is you with your red flag waving it around going, yes, it's intussusception. How do I spell it for my paperwork? All right, so intussusception is bad. Recognize it from the poo. Now, other symptoms you might get: bile stilled vomit, and that's late on. So if you're getting bile stilled vomit and you're getting abdo pain and you're getting signs of shock, you're thinking about both these things: intussusception and volvulus. Both of them can cause hypovolemic shock from the tissue damage. Intussusception, as we've just said here, red currant jelly stools. Whereas, let's go back to volvulus. Tell me about the poo, bloody or dark red. All right. So make sure you investigate that dirty little nappy. All right. So causes, I looked it up, but it's not really known why this happens. And they said it can be linked with infections and swelling in the bowel itself, but they don't really know at the moment. And again, I know I say this every week, but intestinal issues in neonates would be an excellent dissertation topic. Because you ask around, has anyone who you know ever diagnosed a suspected intussusception or volvulus? People forget all about them when they leave my module. Don't forget about them. Right, next, projectile vomit. So here is pyloric stenosis. Now, this is really exciting as well because it's to do with the digestive system too. So let's have a little look at the stomach, and let's have a little look at the pyloric part. So what happens here is the stomach, we've got a little close here, so we can't actually get anything through the stomach into the intestines. That's a problem, isn't it? So let's read about it. Pyloric stenosis is an abnormal narrowing of the outlet from the stomach to the small intestine. So the food and fluid that comes in via the esophagus goes on with its little digestive system. I'm sure you can write about that from your Nanny Pat module, the 5 stages of digestion. And instead of normally going through the stomach, through the duodenum, into the small intestine, it gets cut off and it's blocked from going through its digestion. So, of course, if that's sitting there in the stomach, it can't stay there. So the stomach's going to go, whoa, not happening. You ain't staying here with me. Get the hell out. So stomach rejects it, comes out that way then, doesn't it? Got to go back the way you came. Got to go through the esophagus and vom the hell out of it. So this vomiting is fierce. All right, so not fierce like a queen. This is fierce like projectile vomiting. So the symptoms are you will actually see a forceful vomiting. Now, these, if I was a parent and I seen this for the first time, I would be thinking, exorcist, this child is possessed. Get me a priest. But now that you guys know about it, you won't act like that. You'll be like, oh, projectile vomiting, you said, straight after feeding, you say, I think that might be pyloric stenosis. And everyone will go, wow, you know your stuff. So here's symptoms. This projectile forceful vomiting straight after a feed or very, very shortly after the feed. This baby stays hungry because it's not getting anything. What comes into its stomach comes back up again. So baby always wanted more food. Little greedy little thing. So it becomes a cycle. Get more food, do the vomit. Want more food, do the vomit. Of course, when digestion's not happening, you're not going to get the same amount of splat, are you? So the soiled nappies are going to be reduced. Now we know that there needs to be minimum now of how many nappies a day was it? No, it was 5 wet nappies. It was 2 soiled nappies a day minimum. So if you're getting a reduction in that, some people might think constipation, but then if you're talking about the feeding patterns and you're reassessing the history with the feeding and the vomiting, you're probably going to go along the differential diagnosis of pyloric stenosis rather than a constipation. You might be thinking some type of blockage or obstruction like volvulus and intussusception, but they come with a different coloured poos, whereas pyloric stenosis has a complete reduction in poo. So the baby's going to be underweight because they're malnourished. They might also become dehydrated. And when a baby of less than 28 days becomes dehydrated, it's very difficult to reverse that. So you need to recognize the signs of dehydration, and putting that all together, be thinking about these three intestinal emergencies. Again, this baby needs to go to hospital and have an operation. So the three intestinal emergencies which I've discussed with you, they can present in little babies as little as up to 28 days, but they can also be present in infants. So if you get like a 2-year-old baby, please don't rule this out. These can still happen to them. It's just that in neonates, this is when we tend to observe it first because it happens from birth. But there are situations in which the baby doesn't have this and develops this. So, like I said, it might be through infection, etc. It might be just through something random happening. But scans should reveal what's going on in the abdomen for this. All right, finish that bit. Dehydration. Now, I know you know your dehydration by now because we've gone over it in pediatrics. We have gone over it in newborns, and now we are going over it again in neonates. So the stuff you're going to see here, the fontanelle. Now you're not going to see that in big children. You're not going to see that in anyone over the age of an infant. But this little neonate that's up to 28 days, this is where you'll see dehydration. You will see the sunken or depressed fontanelle, a little bit pressed in. Sunken eyes and lack of tears, so dry crying. Wants to drink, might vomit, especially if you're thinking about your pyloric stenosis. And at this stage, babies aren't really drinking too much water. Most of them are just drinking breast milk or formula if you've gone down that route. Decreased urine output. You know how much a baby's supposed to be wet in their nappies, how many wet nappies there are supposed to be a day, how many feeds there are supposed to be a day. Now that you're armed with that information, spotting dehydration is going to be a lot easier for you. So don't forget it. Write it down somewhere for your board. Yeah, you don't see up to 28-day babies very often, but when you do, I tell you what, you damn well better know what you're talking about because they are so precious. So you make sure that you know about how often they should be feeding, how often they should have wet nappies, dry nappies, and you make sure if the baby is dehydrated that you're on the ball and you recognize that. All right, whew, getting all stressy, aren't I? Sorry about that. All right, the other things that we see in dehydration: a change in the vital signs, heart rate, breathing rate, change in their little mood. They might cry a bit more, be irritated, annoyed, and they might be a little bit weaker or a little bit floppy. And then, of course, we've got the tugur, the tightness of the skin. So dehydration, massive red flag, goes in with our intestinal emergencies too. Again, you've seen this slide before. I put it in a circle this time to make it seem like a different slide, but I know there's no fooling you. So we're looking at infections and sepsis. During the first 4 weeks of a baby's life, those infections can be really serious and really hard to reverse. So we need to detect them. So sepsis and infection is more than just saying, oh yeah, temperature's a bit up. We need to know how much is the temperature. Check it in both ears. When you take the baby into hospital, they're going to check temperature in different ways. So it can fluctuate really very quickly. So when you're taking the temperature, note it, but also have a little feel of the child. Feel of the head, feel of them centrally, feel the hands, the peripherals, and the feet, knowing whether anything is cold or anything is particularly warm. Babies will get warm heads quite often when they've got infection because it's a third of the body weight. That's where you feel, oh my God, hot head, little thing. So you might feel a little bit of heat generated around the baby's head. Keep an eye on the temperatures, take it more than once. So signs that are above and beyond the temperature, we have got the respiratory distress, that grunting, Really, really, really bad sign. I tell you from experience, and it's a sad story that doesn't end well. But if you hear grunting, that baby is near death. Lethargy, floppiness, irritability, crying a little bit more. You can have hypothermia as well as hyperthermia. So remember those temperatures under 36 doesn't mean you've got to bash your tympanic, it's not working. It means shit. This baby could have sepsis, could be in septic shock, could be in organ failure. A hypothermia is a sign of sepsis. Hypoglycemia or hyperglycemia as well. So hypoglycemia is going to be a sign because of the metabolic function, whereas hyperglycemia is in the signs of any type of infection, tends to let the blood glucose go above 8. Hypotonia, again, that's floppiness, so no muscle tone in them. The babies they're scrunched up, aren't they? They're not like da da. They're scrunched up. So if they go a little bit like that, you're thinking that is not a normal position for a baby. Acidosis, which you won't really detect. You might, smell it a little bit, but there's nothing really that you can do to detect acidosis. Apnea or different types of breathing spells. So you might get fast, slow, fast, or irregular breathing patterns. You might get really fast breathing or slow breathing. So it's important to count the breaths over a minute. It's important to detect whether they're regular or irregular. Please do this. Please don't just look at the baby for 15 seconds and multiply by 4. Please take the time to assess this neonate properly. Cyanotic spells. Believe yourself. Believe the parents and caregivers. Their lips were blue. I swear they were blue. Yeah, well, now they're pink, aren't they? No, I swear they were blue. Listen, you can have little periods where you go from cyanose to normal again in a neonate. Believe the people. They have a brand new baby. They are going to be staring at it 24/7. They are going to notice changes. You come in here, you say, no, the baby's not cyanose. What are you talking about? No, you need a bash to the head if you're doing that. So believe the parents. Poor perfusion. So again, that's going to be your cold peripherals. That's a sign of septicemia. We've been over this. So I'm hoping that this is all coming in now and you're feeling a little bit more confident about seeing the signs of dehydration and of sepsis and infection. Next one is hypoglycemia itself. Sorry, I think my dog is trying again. No? He's given up. Sorry. All right, so hypoglycemia. First of all, I've put a little picture here because some people don't know where to take the blood glucose level. And that's not a criticism. This is not something you generally get shown. We asked you the question, oh, in pediatrics, in babies, where do you take the blood glucose reading from? And everyone says, yeah, the heel. And we go, yeah, you're right, the heel. But have a look in here. You don't want to take it from the main bit of the heel. You want to take it from the sides. All right, so this is what you should be looking at in there. So the risk factors for hypoglycemia in neonates, it goes without saying that the baby's kind of size and what they've taken in for feeds will affect it. But let's think about some other factors. So the mother's age at the time of birth. So incredibly young, incredibly old. If the mother is diabetic herself, these babies that come out and then they are called either too small or too large. Now, you wouldn't believe it, but I was a very large baby. I was 9 pounds 11, so that's almost 10 pounds. So that is a big baby. So I might have been at risk of hypoglycemia when I was a little baby. So I probably will have some of this to make up for that fact. Anyway, let's get back to this. So mother's age at the time of birth, mother being diabetic, tiny babies, big babies. If they've had previous infections, if their growth while they were growing in the womb, if that was slow, If it said, in the notes, you'll find this, and it will say baby's height, and it'll be like, I don't know, 3 millimeters under average or something like that. It will have comparisons to average, and then that will be documented throughout their notes. So any type of hypoxia post delivery, what can cause that? Remember when we had a little look at the newborn? We looked at hypoxia, what might cause hypoxia, prolonged time in the birth canal, cord around the neck, distress, those kinds of things. Hypoxia post delivery and during the delivery can lead to hypoglycemia. Premature babies who aren't fully developed as well. So there's your risk factors for hypoglycemia. Now, what will you notice about the baby apart from the blood glucose reading? The color of the skin, they might be a little bit, tiny bit like pinky white or pale. They might have different type of breathing rates. So you're looking at apnea, which is stopping breathing, or rapid breathing, or a pattern of both. That's mostly how it will present to you. Hypothermia, they go hand in hand, don't they? Person with low energy doesn't tend to be able to keep warm. The usual grunting, red flag, alarm bells, jitteriness, irritability, kind of like jumpy babies, not feeling very well, vomiting a lot. You might actually find in the nappies as well that they're being overproductive in that way. Lethargy or floppiness. And in worst case scenarios or bad case scenarios, tremors and seizures. Don't forget you can get hypoglycemic seizures. I want to talk about your mentors and yourselves and when you choose to do a blood glucose in a child and in a baby. Now, I'm pretty sure I've had this conversation with you. I say with you. I'm pretty sure I've had this conversation with my computer screen. But what I'm getting at is a lot of people don't think it's right to do a blood glucose on a baby because they don't think the baby's going to have diabetes, as they would call it, and it's not worth hurting the baby or distressing the baby. My advice to you is if you think this baby is unwell, no matter what age it is, check the blood glucose. Okay, if it's an accident, if it's trauma, maybe you don't want to. That's cool. I don't think you need to if it's trauma. But if you have a baby with strange behavior or vomiting or strange digestion or nappies or whatever, something's wrong with that baby. If you can't see the signs of infection and you don't do a blood glucose, you're a fool. You need to gather up every single bit of information you possibly can to arm yourself with to be able to say, I think this baby's got an infection. This baby's not well. We're taking the baby in because you know how quick they're going to compensate. So, looking for hypoglycemia. Now, as usual, we're going to carry on to look at the safeguarding things. So I'm not going over them all over again. We've talked about safeguarding. We've talked about non-accidental injury. We've talked about sudden infant death syndrome. Please do some further research on that. If this is to be your OSCE, you will need to talk about safeguarding in full. So just a summary on your assessment of the neonate. The neonate is a baby that's up to 28 days old from birth. We know our newborn resuscitation algorithm. We're going to make sure that we know our neonate and our pediatric child resuscitation algorithm. And if we don't know it, we're going to make sure we have it in our phones on the app. So when we're going to a sick child, we revise that. That advice is the same no matter what. You go to anything that you're unsure of, that you don't go to week on week, you're going to forget it. We've all got skill decay. So have somewhere where you know you can flick to in your book or you can get on your phone where you have this information. Back to the assessment of the neonate. Dr. ABC, hands off, pediatric triangle, work with breathing, circulation skin, appearance, brackets, tickles, observations, vital signs, summary of parental concerns, that's your history taking. Read maternal notes, find out a little bit about this brand new baby's history. Assess the feeding type. I should have written in there and nappies as well, but that comes all in together. Check for volvulus, intussusception, and pyloric stenosis. Then check your red flags: infection, sepsis, dehydration, hypoglycemia. Consider everything about safeguarding and then make your plan. Be careful. Don't take anything for granted. Assess, assess, assess. And if you're in any doubt, take that baby in for a pediatrician who knows what they're talking about to assess that baby. All right. Good luck. Cheerio.